We would like to thank Biogen and Scholar Rock for their generous support of this symposium.
It's wonderful to have the opportunity to talk about spinal muscular atrophy with all of you today. And I will try to leave time for questions at the end. This last decade has been an incredibly exciting time to be involved with thinking about and caring for individuals with spinal muscular atrophy in particular. And today, in order to talk about current treatments very briefly and the ongoing research, what I'm going to do is quickly review some of the background of spinal muscular atrophy. I want to acknowledge that I belong on a lot of medical advisory boards and receive clinical research funds from a number of pharma companies, but that will not affect my comments and recommendations. In adult learning, I always like to make sure that we focus on what we're going to talk about, what we're going to learn today. And I think that these 3 points outline the important topics that I'll cover. One is just to very briefly review the signs and symptoms of spinal muscular atrophy, as well as the methods to confirm the diagnosis, and then to move on to comments relating to the time-sensitive nature of treating spinal muscular atrophy, because it is a potentially progressive disorder. The information about treating early has led to a new component of diagnosing spinal muscular atrophy, which is the inclusion of that in newborn screening within the United States. And then finally, we'll talk about the consensus standards of multidisciplinary care, as you heard Dr. Hoffman talk about briefly, as well as disease-modifying therapies, both the ones that have been used to enhance individual production of the SMN protein, gene replacement therapies, and other therapies which benefit individuals with spinal muscular atrophy, but which are not directed toward increasing the SMN protein. One of those you heard come out in the questioning, which was mestinon or pyridostigmine. My time working with spinal muscular atrophy goes back many, many decades. And here, what you see are pictures of some of the German neurologists who last century first made clinical descriptions. Werning and Hoffman gave their names to the early onset disorder. And here are some historical pictures that I've been given permission to use that can very clearly and graphically demonstrate that there is a spectrum of weakness, with the most clinically affected individuals having presentation early in life, and then other individuals having lesser degrees of weakness and being able to sit independently or bear weight independently before they begin their progressive course. This picture is actually a picture of the spinal cord and the spinal roots of an individual with spinal muscular atrophy. And this is what led people to believe that it was truly just a motor problem, because normally these roots, which are here very skinny compared to the big, robust, fat ones in the posterior part of the cord, these skinny ones are the motor roots, and normally they're much bigger than the sensory roots or the posterior roots. But in SMA, they're very, very small. So this atrophy of these anterior spinal roots or motor spinal roots, and then the decreased number of motor neurons in the spinal cord, is what led people to believe that this was primarily a motor problem. Again, here you can see the anterior horn cell or motor neuron in the anterior horn of the spinal cord, and then this anterior root. The problem is here in spinal muscular atrophy. To give us a sense of time, it wasn't until 1995 that scientists in a team in Europe identified the SMN gene. It's on chromosome 5. There are other things that are clinically, other disorders that are clinically called spinal muscular atrophy, but this is SMA associated with chromosome 5q, or the one arm of the fifth chromosome. And that was identified as this very common disorder in 1995. But as you can see here, hundreds of years before, people were making this clinical description and making the diagnosis. Every individual with spinal muscular atrophy lacks the SMN1 gene, and that's what's actually looked for in the genetic test to make the diagnosis or in the newborn screen. But if individuals didn't have any backup, it would be a fatal disorder, it literally intrauterine fatal. But humans have a very similar backup gene called SMN2. There's actually only one nucleotide base difference in exon 7. The exons are kind of the components or the moving parts of a gene. And exon 7 has only one nucleotide base difference, but it's enough to change the configuration of the gene so that when it's read, when it unfolds into RNA and then is read, and amino acids and proteins are coded from it, it puts it out of alignment so that most of the transcripts lack exon 7 and are therefore very fragile. So 90% of all the protein produced by SMN2 is short-lasting and not very effective, with only 10% being functional. But if you have a number of copies of SMN2, that provides the individual with some SMN protein. Now, this is a very complicated slide, and I don't want you to read it. I put it out here to show you how clinicians and families try to make sense of the spectrum of spinal muscular atrophy in years past, with the lower numbers indicating the more severe weakness associated with the spinal muscular atrophy. So individuals who never had the ability to sit independently were considered type 1. Those who could sit but not bear weight were type 2, and those who bore weight and frequently walked independently for some interval of time were type 3. And this still gives us a sense for long-standing cases of spinal muscular atrophy, individuals who've had a disorder for a period of time. You can sort of sort out where you are on the spectrum based on this. But this whole classification is becoming less helpful because this is all going to be modified by knowledge of how many copies of the backup SMN2 gene are present, which wasn't known until the last decade, and by what treatments and the timing of the intervention of treatments. So we are living through a process in which all of us are working to reclassify spinal muscular atrophy. This is a graph from a natural history study, one which no treatments were offered, but one in which multiple teams across the country made observations on individuals with spinal muscular atrophy in order to demonstrate what the likely rate of progression was. Because if you have a disorder where individuals survive for a number of years or walk for several decades in other circumstances, you don't want to have to wait for years to see if a treatment alters the outcome. What you really need is a trajectory, a sense of how quickly there is change in motor functions or survival. And then when you then implement a treatment, you can have a more prompt, a more clear response and feedback about whether you're making a difference. So this is one of the natural history curves created through observation. I do want to make very clearly the point that while there's a general relationship between the number of backup copies of SMN2 and the severity of weakness in spinal muscular atrophy, it's not an exact relationship. So that you can see here, for individuals who throughout their lifetime were never able to sit, there is a difference anywhere from 2 to 5 copies of SMN2. It probably relates to the fact that sometimes there are copies present that it may not be as effective or may be altered or damaged in some sort of way. The other thing that makes this a non-linear relationship, and therefore, for example, some individuals who are walkers who only have 2 copies on rare occasion, or as I say, individuals who never sit who may have 4 or 5 copies, is the fact that there may be other modifying genes that we're not aware of yet. Okay? But in general, it gives us a good general guide to the severity of spinal muscular atrophy. Now, many individuals who have been diagnosed over the years with spinal muscular atrophy are probably not aware of how many copies of SMN2 they have because it was never clinically available as a test. It hadn't been even identified as an important factor until the last 5 to 10 years. And much of the time since then, it has been available as part of clinical trials to help categorize individuals and match them with other individuals. It is now available through genetic testing. So in some circumstances, in order to offer the testing to young men and women who don't have spinal muscular atrophy, but who want to know whether they are carriers of it, in order to optimize the outcome of all their pregnancies. I absolutely agree with my colleague Katie, Dr. Hoffman, about the issue of multidisciplinary care. You can see here, and what this is actually a survival curve. And the details aren't important as much as you can kind of see that back in the years prior to there being any disease-modifying therapies, even in fact, prior many times just around and about the time when the gene was identified, just putting into place multidisciplinary care, meaning good nutrition, care for bones, good respiratory care, and so forth, made a big leap forward, a big improvement in the outcomes. And I want to share with you my absolute conviction that even with the existence of disease-modifying therapies and even gene replacement, multidisciplinary care remains a very, very important component of what is available and the treatment available to individuals with spinal muscular atrophy, because there are still many things that we need to learn about the response to treatment and ways of avoiding problems. Okay, I kind of did a quick inventory of these: respiratory, nutrition, bone health, issues of functional mobility, and then all of the issues relating to orthopedic things. Prevention of contractures due to potential decreased bone density, and then issues having to do with joint integrity, not only the hip, but the hips, the knees, and the feet in particular, and then issues trying to manage and minimize the development of scoliosis or curvature of the spine in individuals with trunk weakness from spinal muscular atrophy. Oh, thought that this was a fancy one. Here we go. Showing all the different sorts of things. And again, I think individuals with SMA need to surround themselves with all of the support, you know, the family and caregivers who help them, but then all of the other individuals who have something to offer: primary care physicians, pulmonologists, rehabilitation specialists, orthopedists, nutrition and bone health specialists. And then obviously there are medications of general support as well as those disease-modifying therapy. And then again, genetics is playing an important role in the lives of the family members and individuals with spinal muscular atrophy. I mentioned that the difference between SMN1 and SMN2 was in exon 7. Again, there's just one nucleotide-based difference. But what it does is if that is skipped, the RNA readout is such that it produces a protein that's fragile. I'm going to go through various forms of treatment that a few years ago were only in clinical trial, but now are, which are FDA approved for use in spinal muscular atrophy, and talk a little bit about the mechanism of how they work. I'm going to go in order of when they were introduced clinically to families. The first drug to be approved by the FDA was nusinersen, or that's the chemical name, what some people know as Spinraza. And what it does is it very selectively targets a component of the exon 7 in SMN2 to make sure that the exon 7 is included or read through, okay? So exon skipping or oligonucleotide, antisense oligonucleotides it actually, in this sense, prevents the skipping of this exon and includes exon 7 into a full-length SMN protein, okay? And that's the mechanism of action. Nusinersen is administered into the spinal fluid that bathes that spinal cord you saw in the early picture, and affects motor neurons very closely, but also does have other impact. And that is something that we're working out over time. It's administered in its current form in several loading doses over 2 months to get up to a steady state level in the body, and then needs to be repeated every 4 months. Now, what these are just motor scale scores, just one way of looking at the response. So you can see here in the very lowest graph that with no treatment, what they called sham treatment, okay? Because these the early trials were carried out on children. They were carried out with the physicians and the families and the physical therapists not knowing whether the child was in one of the 2/3 of the group that was getting active medication, or whether they were in the sham group that was just taken away to a procedure room and who had a little bit of sedative medication to kind of blur the memory, and then topical cleaning of the skin and just a pin stick and a Band-Aid applied. So that was the sham treatment. So it was a very objective study because it was blinded, okay? And no one knew until they uncoded the study which children had the active treatment. You can see here that the children in the sham group lost motor scale score, whereas the children who were treated with the active medication had a very significant improvement in their motor scales over time. And in fact, that never happens in untreated spinal muscular atrophy, that at the time of after the time of diagnosis, individuals with spinal muscular atrophy, whether the diagnosis is made during infancy or childhood or adult years, post-diagnosis without treatment, motor skills are lost. And you can see here that they were so clearly gained that when the interim analysis that was planned prior to the study was done, there was such a dramatic difference between the groups that the study was called. It was ended early, and everybody was given the active medication and treated. The other reason I show you this is that the scale has been actually altered to include the response of individuals who were treated before they even developed symptoms. So whereas the children and the infants and the children in the initial trials were treated after they were diagnosed because of symptoms, this was a very small group of 25 infants, newborns in fact, who were diagnosed before newborn screening because the parents were either aware that they were carriers or there was a family history leading to the individual child being diagnosed. These children were treated by 6 weeks of age when none of them had any symptoms, and you can see that they had this very, very dramatic response and improvement. Yeah. So this is one of the things that made us convinced that the same treatment applied earlier in life has a bigger impact. Now, some of these early trials were done on individuals who were already sitting and who were older. But what we are doing here is looking at upper limb motor scales, upper limb. And you can see that those who happened to be enrolled in the trial earlier and received their first dose of disease-modifying therapy at an earlier age had a more dramatic response than those individuals who were enrolled at an older age. Okay. And this is a different way of looking at it. But what you can see from this is that when you look at these individual milestones, you can see that looking where people were before treatment at baseline and afterwards, that all of the response in this afterwards kind of graph or chart is greater in the individuals who were treated early. But as you can see here, there is still response in the older treatment. So this is not in any manner meant to discourage us from beginning treatment if we only become aware of a case, of a diagnosis of an individual with this disorder later, or if a drug is only approved later in life, because we all have been working to assess the response in older individuals or individuals who, for a variety of reasons, might have started their treatment a bit later. And there frequently is very, very meaningful response, even started later. And just to emphasize this point, this is a graph of a number of individuals who were walking, what we used to call type 3, but ambulatory individuals who were treated. And what you can see is that their distance walked over 6 minutes is either improved or maintained over a long interval of time, which again is something that you do not see without treatment in spinal muscular atrophy. So those slides kind of complete what we started off with, which was just the first type of medication and clinical treatment that went through trial and has now gotten FDA approval for treatment of individuals at all ages. The second type of treatment that has now gotten FDA approval in the United States is gene replacement. You have to be very careful. We don't have time to talk about all the kinds of gene therapy, but I do want to emphasize that the type that has been used in spinal muscular atrophy to date is gene replacement, where there is synthetic building of a functional replacement gene, and that it's then administered to the individual to get into their system. Onasemnogene abiparvovec, or what some people know instead of by its chemical name as Zolgensma, which is the brand name, is pictured here in cartoon. This is the synthetic transgene, which is an exact duplicate of the SMA gene, SMN. Then you have to have a promoter, which essentially is instructions on where, what kind of organ, what part of the body do you want this gene to be sent to, okay? And then just some technical things to kind of keep it intact. The way that genes have been replaced is using biology to guide us. Because this is something foreign to the body, and the body tends to try to react against foreign protein, whether it's a splinter in your finger or whether it's a tuberculosis germ presenting itself. Our body tries to fight these things off for good reason. However, viruses are very sneaky. Viruses have always known how to get past the immunologic barrier that humans have. That's why, for example, some of us have, that herpes type 1 cold sore on your upper lip, and it gradually gets better and goes away. But then if you get run down or overtired or ill, years or decades later, it comes back. It's why many years after chickenpox, humans can develop shingles, which is essentially chickenpox virus coming out in one neurologic dermatome. So we don't know exactly how the viruses do that, but we know that they can. So for gene therapy, what scientists have done is take a very innocent virus, remove the infective agents, but keep the basic capsid in the core and enough command information so that the virus knows how to get into the body, and then produce and stuff what they call these capsids with, excuse me, turn this down. Okay. Stuff these viral capsules or capsids with the synthetic gene. And then many, many copies, like 10 to the 13th or 10 to the 14th, are administered. Okay. They pick a kind of viral vector that will not try to incorporate itself into the human gene chromosome gene pool, because there's a concern that that might be associated with potential for mishap or oncogenesis or tumor development or something like that. So that's what they mean by non-integrating. And you want something that'll be stable. Okay, so this is what they've done for spinal muscular atrophy. This has been administered by a single IV bolus in infants and is now approved for use. This is just a cartoon kind of showing how all of these viral capsids get into the cells, get to the nucleus. The transgene uncoils and turns into DNA that then uncoils into RNA and produces protein, the SMN protein. Again, very, very busy slide. But the point is that you saw that initial natural history slide that showed that without any intervention, very few infants will survive beyond 20 months of age. And what this is the first several cohorts of individuals who were treated at Ohio State University with the initial viral vector with this transgene at these various ages in the first year, first few months actually of life. And you can see that all of those individuals were hale and hearty, lived well past the 20 months of age. What you'll see in some of these other slides is that they not only survived, but they improved their motor skills. So you can see here that the complexity and the number of motor skills that were developed after treatment was very significant, with some of those individuals who were treated, between 6 and 24 months of age, even beginning to walk independently. Again, at this point, Zolgensma has been approved because of those trials in infants. It's been approved for use under 2 years of age with spinal muscular atrophy. There was an initial trial that began and was held, and that now is ready to restart with intrathecal, or administration directly into the spinal fluid of that gene replacement viral vector for older individuals. But that has yet to really be initiated as a clinical trial, so that's a future potential. And we're all looking very much forward to seeing how that goes. There were a few individuals treated in the trial that stopped to have clarification of some safety issues. I'll move on to the third type of disease-modifying therapy that's been used for spinal muscular atrophy. And this is a different way of promoting or enhancing the production of SMN protein from the altered or the mildly altered SMN2 gene, right? And this is with an oral agent that is less specific to spinal muscular atrophy. Okay, we talked about the nusinersen targeting exactly the part of exon 7 that was different. This oral agent is in a group of chemicals, a group of chemicals that affect the splicing of DNA to RNA to protein, right? So that whole splicing process that produces protein can be impacted. So this is very effective because it is given, it's easier to use, it's given orally, but it's not as targeted. And the question always is, and what people have been looking for very carefully, is to make certain that it has a big impact on the splicing of the SMN protein, but that it doesn't alter in a negative way any of the other billions of splicing actions going on in the body. Risdiplam is the one that has been most studied and in fact has been approved by the FDA for use in spinal muscular atrophy. There are others. The first and closest to being through a clinical trial is branaplam, and I'm sure there will be others that will follow. There have been, but since this has all started much more recently, there's a lot less data to present to you, but there has been very important observations made, not only in infants, but in individuals all the way up to 60 years of age. And since this has been approved based on that data for individuals, and they started off by having it be from 2 months of age because there was very little data to be observed before 2 months of age. 2 months of age up to throughout life, through adulthood, and more recently, additional data has been collected and presented to the FDA so that it is now approved in newborns as well. It can be given orally or by G-tube. Because it's administered orally, it has a systemic distribution throughout your entire bloodstream. It's absorbed from the GI tract into your blood and then goes evenly throughout the body, rather than being concentrated only in the nervous system, with small amounts being leaked out, as with nusinersen. Okay. This is, again, just a survival curve showing that with this oral splicing modifying agent in individuals with SMA, it prolongs survival. Here's a functional assessment, again, looking at several dozen individuals being treated, infants being treated, and looking at very carefully at swallowing and feeding abilities. This was important because the individuals, the scientists who've been studying this were very interested to see if systemic administration of one of these agents would have an improved impact on some of the cranial or cervical motor neuron pools. So things like swallowing, managing secretions, and upper extremity function. Again, we have small data. It's very, in this group, and it's very difficult to make head-to-head comparisons between the different agents as of yet. Part of the difficulty is that although there were greater numbers in some of the early trials with the others, no one knew how the individuals with SMA would respond to the treatments. And so the outcome measures were much cruder at the beginning, just frank survival, ability to hold head up, ability to sit, just sort of some simple basics. And no one quite expected that the results would be so positive and blow everybody's mind to the extent that they did, that those early trials didn't carefully quantitate at the beginning swallowing and feeding. Additional observations are being made on those cohorts with the other kinds of treatment, with the gene therapy and the nusinersen. And so we're getting a lot of data, and it is showing that great impact and improvement is being made in those areas. But again, I think that the circumstances are different between the trials, and it makes it difficult for both physicians and families to ask or answer the question, is one particular approach better than another? Again, Firefish is the study with young infants, but these were symptomatic infants, so these were not the ones treated in the newborn period. And you can see that, again, these incredible numbers of children who attain milestones like sitting independently here, or in some of the other ones, you can see the meeting the swallowing and feeding milestones, and a few even walking, although many of the individuals in those trials have not been treated long ago enough or aren't old enough to really check out all of those milestones. This sunfish is, again, treatment in older years of age. So this was individuals between 2 and 25 years of age. And again, you can see anywhere from stability to improvement in their motor scale scores. Jewelfish is, again, an even broader age range, between 2 and 60 years of age, of symptomatic spinal muscular atrophy, who had stability in their motor scale scores over time. Again, stability is never seen without treatment in spinal muscular atrophy. I think you saw this one before, the difference between pre-symptomatic treatment and treatment after the onset of symptoms in infants, and this is with the intrathecal nusinersen. But I also wanted to show this, which is the gene replacement, to make one other point. It not only makes a difference as to the age at which the treatment or the time since symptom onset, or here with pre-symptomatic infants, acknowledging that it was a pre-symptomatic onset of treatment in terms of the outcomes, but there does appear to be a difference in response to treatment depending on how many copies of backup SMN2 gene you have. So that here in infants who were treated in the newborn period before symptoms developed, all of them attained milestones in a very dramatic and heartwarming way. But those individuals who had 3 copies of SMN2 not only attained the milestones, but they did it at the expected age. This gray band is the broad range of normal. For example, we all know that some kids walk at 10 months and other kids walk at 18 months. So we have this broad band to show what is a normal progression of motor milestones. And you can see here that all of the individuals eventually get there who have, in this group of children with spinal muscular atrophy, who were treated in the newborn period before they had symptoms. But if they had only 2 backup copies, they attained those milestones and made those gains in a slightly slower fashion. This is, again, Rainbow Fish, which is the very small study with about 12 infants who were treated with the oral risdiplam, this splicing improvement agent, to enhance the spontaneous production of SMN protein. What you can see, again, is that these are infants with 3 or more copies of SMN2, and they fall within the expected age range for attaining their milestones almost exclusively, whereas those who had only 2 attained the milestones, but more of them fell outside the normal range. With all of this information, over time, now 47 states, this is already out of date, 47 states in the United States are including SMA in their newborn screening programs, and 97% of all births are covered by the screening in those states. And this allows families to have the diagnosis made and treatment initiated within the pre-symptomatic interval. Even with all of these incredible gains in knowledge and multiple FDA-approved treatments, we aren't at the end of our journey improving the outcomes for spinal muscular atrophy. We know this much, but there's much more, I believe, that we really want to know that we're still working on. Let's talk a little bit about what those things are. Okay. Again, I won't, for time's sake, I won't spend much time on the things I've emphasized that we've learned already from the research and observations. But what we really want to know are, can we identify any other prognostic factors beyond the copy count of SMN2 gene that will help us predict how people will respond to treatment? Who might benefit from combination therapies from the very beginning? Do these other prognostic factors, genes or environmental, provide us with other options for treatment, right? We know from the fact that infants who are treated pre-symptomatically from the newborn screen who only have 2 copies, the fact that they don't do as well as those with 3 copies, that there has already been some motor neuron or motor unit loss by the time of birth. So will there be a role in the future for prenatal or intrauterine treatment of infants with spinal muscular atrophy? Interesting question. I want to go back and emphasize that we're not just, I know that I am a child neurologist and tend to really focus on infants, but we've certainly learned an awful lot, all of us, from observing some of the long survivors of spinal muscular atrophy, as well as observing those individuals with milder disease who are responding to multidisciplinary care and who have now begun to embrace the disease-modifying therapies. Part of the problem with assessing how we're doing in that regard is that we don't necessarily have outcome measures that are very easy to use or very convincing. In other words, all those motor scale scores that I showed you with the graphs that go across the page, look at things like head control and trunk control and sitting independently and rolling and crawling and bearing weight and walking. But there are some individuals who may not make that complete progression, but who still respond very positively to disease-modifying therapies. And we're working very hard on this. Part of this has been accomplished by developing, validating, and using upper extremity scale scores. So the RULM or the PUL are two of the very commonly used motor scores for upper extremities. And if there are any adults with SMA or older children with SMA listening, you may have already had this monitored as you're in your multidisciplinary clinic or in your therapy. These are the kind of things that we can use to convince the payers to fund clinical treatment with these for individuals who are not in the newborn period. Looking at respiratory volumes and power is something also that's very important because, of course, breathing and your respiratory muscles are muscles, and that's an important outcome. But there are even some subtle improvements on the surface that have a very profound impact on clinical quality of life and outcomes. So, for example, I've known individuals who go from being unable to master a joystick to using it for a short while to using it as much as they want all day long for anything they want. And if you can master moving and controlling a joystick, you can control your environment, your music, your lights, your computer, your power wheelchair. And those are things that there is no motor scale score to quantify quite yet. So I really encourage all of you to really think about the things that you can do and the things that you want to do and what kinds of movements, what kinds of endurance would make a big difference in the quality of your life, and to focus on those and make sure to very actively share that information with your therapists and with your primary care physicians and your multidisciplinary team, because those are the things that are going to be the key to enabling additional treatments for all individuals with SMA. I have lots of other questions. I mean, what role will gene editing play? Is that, and this is something where rather than trying to replace the gene, they're talking about CRISPR, if any of you have heard that term. CRISPR-Cas9 is probably the leading type of gene editing where that's something that can kind of fix a mutation in a gene. Right now, we cannot use gene therapy at all to anybody who has antibodies. So if you've accidentally been exposed to this uncommon gene that they selected to be the one for the gene replacement, you can't use the gene therapy. But either for individuals with pre-existing antibodies or over time, we now have individuals who were treated with their first gene therapy about 5 to 6 years ago. And that was a very tiny number. It's been much greater within the past 4 to 5 years, or even more recently than that, that individuals with spinal muscular atrophy have received the gene replacement. So far, there's been no waning or wearing off of that effect. But one of the things we have to monitor in these multidisciplinary clinics is whether that happens. If it did happen, is there a way for us to be able to safely repeat dosing of gene replacement in somebody who has already developed antibodies from prior treatment? We've talked about combination therapies. What kind of combinations can we put together without increasing side effects? So far, the medications we don't have time to go into it in detail, but have really not been prohibitive for the most part. Although with the gene therapy in older children who've been previously treated, there have been some reactions, primarily reversible, but again, some serious. So again, we're always weighing potential benefit versus potential risk. Again, at the beginning, when we first started off and there were no available treatments, the risk-benefit analysis was very much easier because it was so clearly observed that without any treatment, individuals didn't make any progress and in fact always lost motor skills. Now, where we have some available treatments that are clinically approved by the FDA and available, trying to decide whether to go ahead with these and which ones are available depends on your age and other details. Whether you have antibodies if you're young, whether you're under 2 or over 2 for the gene replacement at moment, and so forth. But the question is whether going with what's available commercially, which has already been approved and is not in trial, or whether to try to enroll in a trial, because there are clinical trials now that you will hear in our discussion later on with several agents, or people who've had one agent and haven't had a complete clinical response, offering them treatment in an observed clinical trial of adding on a second agent. So the decision for the family or the individual becomes much more complicated because there's so many more options. And again, sometimes very good data and other times limited data about what the potential side effects would be. I know that there are future technologies that might be able to provide intrathecal access with less inconvenience or less hassle or discomfort than repeated lumbar punctures, but they would need to be trialed and validated as something that doesn't impact the response. Is there something that can be done to minimize the need for control groups or the placebo arms of clinical trials? And the very good news is that the federal government and parent support groups for not just Cure SMA, but also Parent Project to Cure Duchenne, and I know MDA is going to be involved as well, have promoted development of different ways of statistically analyzing and matching individuals so that some of the natural history observation of untreated individuals in the past can be used as an alternative to a placebo control group, which I know from all of our points of view, both as providers and as consumers of medical care, will be greatly appreciated for these rare diseases. This is what I would summarize. We cannot forget the multidisciplinary comprehensive care. It adds a lot to the outcomes with or without disease-modifying therapies. And as people are involved in multidisciplinary comprehensive care, this real-world observation will give us more information about the impact of the disease-modifying therapies. I think as we identify other modifiers to prognosis, we'll be able to individualize the recommendations for treatment. In other words, many of us are questioning right now with the lower numbers of SMN2 backup in even pre-symptomatic newborns, whether combination therapy should be used from the very beginning. And I think that is a question, not a conclusion, and will need to be studied with a clinical trial. Again, I just want to share with the permission from the family, one of my favorite patients who would not be sitting, would not be walking in a gait trainer if it were not for treatments. And even with all of his clinical trial involvement, he still has a very big stack of medical bills there that his mother's letting him decorate, shall we say. So I guess what I'd like to do is stop at this point in time and see if people have questions.
All right, thank you, Dr. Kuntz. We do have a couple of questions, which let me get them pulled back up. So first question is, sorry if I missed it, but any comments on the trials using myostatin or anything else seemingly promising?
Yeah, no, I was just sitting here writing a note to myself saying that I'd forgotten to really emphasize that there are some non-SMN enhancing therapies that people are bringing to the table. These were used before, for example, all the trials of oral albuterol and valproic acid were ones that were some of the first treatment attempts in spinal muscular atrophy. And I think what people found with those is that in general, if you looked at large groups of people, that the difference between the two groups was not statistically significant, but all of us have had the experience that there are some individual people with spinal muscular atrophy who appear to have a big response. So there are still some of my patients who take oral albuterol, and again, this can not be possible during a clinical treatment trial because people want to have a very even match in terms of the different groups. But there are some individuals who are convinced, and I'm convinced, that they have a very positive response. Now, since then, somebody brought up mestinon or pyridostigmine. Again, we're increasingly recognizing that spinal muscular atrophy is not a disorder limited to the motor neuron. And we wouldn't expect it to be, knowing that it affects the splicing mechanism, because that affects all organs and types. But there's no question it affects the motor system disproportionately. But it also affects the neuromuscular junction, that place where the nerve terminal comes down, and then there's a very small gap, and then the end plate on the muscle itself. That's again where an immune process would cause myasthenia. And again, what mestinon does is increases the hang time of the neurotransmitter that goes from the nerve terminal to the muscle, and therefore improves the transmission in myasthenia. And in any disorder that has any denervation, loss of innervation essentially, and reinnervation, like spinal muscular atrophy or ALS, the immature or regenerating muscle end plates have an inefficient neuromuscular transmission. Therefore, pyridostigmine will help with endurance. So that's one of the non-SMN enhancing agents. The most recent, I think, addition to that group is anti-myostatin. And frankly, there's only preliminary evidence, and the trials are really ongoing right now, and so we're waiting to see. Basically, myostatin is a naturally occurring agent that limits the amount of regrowth or hypertrophy or bulking up of muscle in response to injury. So, I mean, for example, just to use a crude example, if you had a big injury that took away a hunk of muscle from one thigh, you want it to heal, but you don't want it to start healing and start regrowing and rebuilding and then just keep going indefinitely, because then you'd go from there being a little bit smaller muscle on that side to having really indefinitely huge muscle. So it's just part of the checks and balances in the body that once you start rebuilding after injury, it stops at some point in time. So the anti-myostatin is a biologic agent, an antibody that partially reduces that, partially puts a brake on the anti-myostatin to let the amount of repair be a little bit more exuberant. So it has nothing to do with the mechanism of spinal muscular atrophy. And in fact, it has been clinically trialed in a number of disorders, including myasthenia and others. So I think it's something that we're all looking forward anxiously, because there has been some anecdotal and preliminary information saying that it may be helpful as an adjunct. Personally, I don't anticipate that it will be as powerful as these SMA-directed disease-modifying therapies.
All right. Thank you, Dr. Kuntz. Let's see. Next question is, any status on the study, not sure if active or pending, of using valproic acid with Spinraza?
Mm-hmm. Yeah, no, that's a new one. I have not heard of that being ready to launch. But I think that all of these agents, as I mentioned, are things that we're going to need to try to get some perspective on. As I mentioned, just even simply the valproic acid, I've observed that there's a big difference between individuals in terms of how much benefit they get from adding or taking that when they have spinal muscular atrophy. If we could have the scientists help us flesh out, figure out why, who is it, what is the factor that allows some people to respond so much and others not much at all, because you don't want to take it if it's not going to help, right? So I think that that some combination of using it in combination, or if we come up with some information that will help us understand who we should target with that as an adjunctive agent, would be very, very helpful.
Okay. It looks like the last question that's come in says, I also read a paper on research with increasing the number of long proteins within the SMN2 gene to work with drugs like Spinraza. This would provide more potential candidate proteins for Spinraza to work with and therefore potentially be more effective. Any thoughts or input on this?
I've not seen that paper, and just from your description, I'm not certain I understand what the long protein's referring to. I'm not sure if it's something that's trying to get those fragments that don't last very long and trying to make them a little bit better, and then to see if that improves the response. Sounds like a logical thing to try, but I'm not familiar with the data or that paper.
Okay. That looks to be all of the questions that we've had come in. So thank you again, Dr. Kuntz, for sharing your time and expertise with our community today.